of TBI, because we've been talking to physicists about the technologic point of view, but you have to know the concept of this treatment. So I'll give a little, really little talk on TBI, why we do the TBI, to whom we do the TBI. So to start with, we do TBI when we have to do the HCT, and I think you guys learned it. And so there's two different types of HCT. Of course, CAR-T is somewhat new, but I'm not going to talk about CAR-T today because it's going to be too much. So I'm going to mention what I want to talk is allogenic HCT. So we have autologous HCT and allogenic HCT, right? So autologous, you use your own stem cell to rescue from the high dose chemo. So for autologous, we don't really need to kill anything, or so it's less toxic. We don't have to care about graft versus host disease or anything. But when we do the allogenic, we aim to have the effect of graft versus tumor effect. So that means we have to be careful about graft versus host disease, which may cause 10 to 20% of treatment-related death. But at the same time, this treatment is very strong because they have graft versus tumor effect. They want the grafting to kill the tumor cell. And we don't always have to use TBI to do this. So there's this nice figure drawn in 2010 by Dr. D. And the strongest couple, it will be busulfan, cyclophosphamide, and TBI. And this big TBI means 12 gray, like very strong TBI. But we can have smaller fraction when we don't really have to kill the tumor cell. So it's the balance of intensity of the treatment will be higher if we go this way. But the toxicity also increases as the intensity increases. And this is the strongest regimen for the consolidation with the strongest regimen. And these are the regimen we usually use with the when we have to do the HCT to AML or ALL. So we classify the preconditioning regimen by its intensity. So MAC, that means myeloblastic conditioning. That's we have to do this to patients who have incomplete remission. And it's if in terms of dose, we have to irradiate like more than 8 grays. And for those of you who cannot tolerate these myeloblastic conditioning, like with the age, older people can't tolerate this greater than 8 gray TBI, so they have the reduced intensity conditioning. And for those of you who do not need to consider tumor cell reduction, then TBI could be as low as 2 gray. So if we choose this regimen by the disease or with the combination of the chemotherapy that we choose. So it's not just the TBI. We are doing TBI as a very little part of the HCT, but remember, this is very strong treatment that unless we do apply this, the patient cannot be cured. That's why we accept this treated related death of 10 to 20%. We don't do that if the patient don't need this treatment. So do we do this? Well, I just picked one slide from NCCN guideline that you may have seen. I just picked one case of AAL with pH plus, but the concept is similar. So I just first we go for the induction therapy, and and have response assessment here, right here, even with the AML. And we should consider HCT if less than CR was achieved. But even if we have achieved complete remission, we would consider HCT for AML patient with poor prognosis or AAL patients. However, as written at this NCCN guideline, is very important. Optimal timing of ACT is not clear today. And for and also there should be many variables determining eligibility, and very importantly, the donor availability is not always achievable. So if you don't have the donor, you cannot go for the HCT. So we have to have the right donor, and I'm not gonna talk deeply on which donor is the best switch, but you can see that in textbook. But for if we have to find the donor, and then if we cannot achieve complete remission with the induction treatment, that means patient needs stronger treatment to kill the tumor cell. And that's why we go for 12-gray TBI. It's because they react differently from the drugs. Drugs, they can only go through the blood, but radiotherapy has different way of getting to the tumor. So for those who are difficult to treat with drugs, will usually come to TBI. And considering with or without TBI, who should get the regimen with TBI? It's AML patient. So AML patient at today's point, cyclophosphamide plus TBI is somewhat equivalent or a bit less less not tolerate, but less tolerate than busulfan plus cyclophosphamide. So they usually go without TBI for AML, but with those with very bad, poor prognosis, they may have to go with TBI, or those who failed the previous HCT, they will, and they have to retry, then they'll add TBI. And for those with ALL, many regimen, many clinical trials have proved that TBI with the TBI regimen is better with compared to without TBI regimen. So usually we apply TBI for the ALL patients. And one of the reasons is that 3 to 7% of ALL have CNS invasion at the time of diagnosis, and they relapse in CNS. And CNS or testis are the organ that cannot, the drug is very difficult to go through. So that's why we want to add TBI. We want to add radiotherapy. And if CNS invasion was there before the treatment, we should consider adding CSI of 12 gray in addition to TBI 12 gray. So it's going to be 24 gray. Or if there's a mass created in the somewhere external to the medulloblastoma bone bone marrow, then you have to add a bit more. You have to boost. You have to boost the radiotherapy so that the tumor will receive around 24 gray. So why do we have to irradiate whole body? There's 3 reasons for doing TBI. One is tumor cell reduction. So this is the concept of applying myeloblastic ablative treatment. So those with very bad background of AML or ALL patient, they need to have the tumor cell reduction, so they will receive TBI of usually 12 gray. If not, if older age like over 55 or 60, they may have the reduced intensity of around 8 gray, but we give the TBI to reduce the tumor cell. Then other than that, there are two other reasons. One is host immune suppression to decrease the occasion of happening the graft versus host disease. And also related to that, ablation of host hematologic function to achieve engraftment. So we do TBI for these reasons as well, but usually for those with really bad background, we need tumor cell reduction for it. So for young people, we use 12 gray. And in past, today we came here to help you guys to do the IMRT, but for a long time we've been doing this long SSD method. And this is just take the distance to irradiate the whole body. So here's the beam head, and you put the different table on the wall side, and with the distance, you can irradiate like this, the whole body. But as you can see, the body shape is not in the same distance from arm to arm. So we put like bolus, like water density things surrounding the body to make the same thickness and irradiate from one side, and then flip to the other side and irradiate from the other side. So physicists, I'm sure you'll think, well, this won't be same in the whole body. True, it's not. So usually the lowest will be around 8 gray and highest will be around like 14 gray. So we've been doing this for so long and we have achieved certain good outcome. So this is the idea of long SSC. And for the lung, because the air is inside the body, what we do, we add shield on the lung area to just block, to have the lung to have around 10 to 12 grays. So this is what we've been doing for so long time. There's many methods that you can do with the, dividing, adding like dividing three section, or we can take distance, we can have patients stand, or any way they can do. But again, in every cases, there are so many uncertainties, and those homogeneities is awful. So it's good. The good thing is it's easy, very easy, and strong to small motion, because there's so many uncertainties that we don't care that much about little movement. But as I've been saying, there are too many uncertainties. We have no idea how much they are getting. There must be more than 30% differences. So, however, we learned a lot from this long SSC data. One is that it's better to irradiate with fractionated regimen than one fraction regimen. This was proven in many other studies as well. And there's the reason why overall survival is better in fractionated irradiation is because there will be high incidence of lung injury with 8 to 10 gray in single fraction. So it's 8 gray. We say 8 gray, but it's long SSD data have shown that in one fraction it's worse. And in terms of a dose rate for long SSD, not IMRT, long SSD, there are reports reporting that dose rate should be less than 15 centigrade per minute. That's very slow. But that's it. This is proven by the one fraction. So if we go 10 gray in high dose rate, it's going to destroy everything. So if you are to deliver one fraction with high dose to whole body, we should lower the dose rate. And that was reported as idiopathic pneumonia during first 100 day is higher in higher dose rate in 2019. So how about IMRT? IMRT, the physicists have had, I'm sure, very difficult days for these 2 days. The precise technical note is noted in this paper. This is very good paper. Please do read them because they have all the setup thing and everything in it. So this is kind of like guidelines. So this is very good paper. But in terms of lung injury, these two, IMRT2, mean lung dose of less than 8 gray may be safer. It's there are 2 reports in 2019, overall survival and incidence of the pneumonitis. They both decreases with the mean dose less than 8 gray. However, if we want to irradiate the rib with like 10 or 12 gray, we have to have the margin. So the mean dose of surrounding those area will be around 10 gray. And if we put the mean dose of the other lung to be 8 gray, then the total mean dose will be a bit higher than 8 gray. And that happens a lot. But remember, we've been doing this, and the 8 gray we calculated in this situation is not 8 gray. Trust me, it's not. So I don't think this 8 gray means too much, but we should pay attention to lung. We should lower the lung if we can, but at the same time, we are treating very difficult disease who cannot be killed by chemotherapy. That means we have to deliver more than 8 gray for bone marrow. So rib is target and spine is target. So we cannot lower those areas. So we just lower the center of lung, and sometimes we go above 8 gray, but that's something we have. Well, if it was between 10 gray, 8 to 10, I say okay as long as the bone marrow is getting the sufficient dose and it's fractionated, then I think it's okay. Because if you are having 8 gray in 6 fraction, you're getting less than 2 gray per fraction. So because I didn't prepare that much, this is about it. And so what's good about IMRT is that we can escalate the dose to the target. There's a study going on that escalate the total bone marrow dose to be up to 14%, and they have really good outcome. And they are lowering the lung and kidney dose. And because kidney is second, kidney failure is the long-term side effect that a patient will experience. So we want to keep the kidney to be lower than 10 gray, but mean kidney dose to be lower than 10 gray. But first of all, we have to cure the patient. So we have to give the certain dose, and we want to, but still reduce the dose that don't need the high dose. So IMRT is the best choice. I mean, IMRT is very good choice, and unfortunate uniformity of dose distribution can be achieved by IMRT, but as all the technologists and the physicists have experienced, it is very difficult to set up the whole body within 5 millimeter margin. Today, when I saw the setup, I realized you guys are using a bit too thick pen. We use very thin pen because we care if we're gonna set up on the really with the laser thickness. Otherwise, it can easily move 5 millimeter. But you guys did a really good job in these 2 days that you achieved to fix the patient within 5 millimeter. That was amazing. I thought it's gonna be very difficult. We trained a lot, so it was really you did really good job. So, but if I could give the advice, draw a line on the arm because the arm changed a lot, and use the thin pen. And I think that's all I can give for today because of small portion of time for the preparation. I'm sorry. But if I'm very happy to have all the questions if you have. Any question? Comment? No?
So thank you so much for your lecture, Dr. Mariko. So I think we have our plan, current plan. Yesterday they have simulated if there's a shift, it's still less than 120%. Let's say there's a 5 millimeter more cranial when we flip the patient. It will be because they segment every 1 centimeter, 1 centimeter, and they control the dose. So it will increase, but it will not be on 120%. Is fine, right? No problem. So let's say when they turn the patient fit first plan, there's a 5 millimeter shift to the cranial, so or caudal. So there will be not, I mean,
you mean the dose will be a bit higher?
yeah, the dose can be a bit higher, but it's not beyond 120%.
Well, it's so you're adding 12 gray in the first place. So we don't care that much of those max, but we care a lot on the mean dose of the lung or kidney. But we don't care if the lung gets max of, let's say, 80 gray. You don't care, right? If you're giving SBRT, you don't care that much. So we don't put that much attention on max dose, but mean dose is very important for lung or kidney. And especially because usually legs, they tolerate double the dose. So I don't care that much, but I want to make sure that whole body have 8 gray because we want to reduce in the first place to have the graft versus post disease. So we have to keep the minimum, and then we don't care the max that much.
Yeah. So this very central lung will receive very small doses, okay, right? Because
mean lung dose is mean lung dose, and that all the bone marrow is covered, is the most important point.
The risk plus margin is covered. Okay.
Well, margin, as long as lip is covered, that's okay. A little bit of underdose of the skin, well, that could happen.
Okay, thank you.
It's always better than long SSD, trust me. So dose conformity is important.
Maybe we have Prof. Jaka here. Prof. Jaka, Prof, kedengaran Prof? Halo Prof. Jaka, masuk nggak suara kita? Prof. Jaka, mungkin ada komentar Prof? Silakan,
Tolong
Prof.
terjemahkan saja sama Handoko ya.
Boleh, Prof.
Sebenarnya kan waktu kita lakukan dulu tahun 80-an itu juga kita menggunakan jarak lebih dari 3 meter. Itu dose rate-nya rendah sekali. Tapi dengan teknik yang sekarang, dengan jarak yang relatif dekat itu, bagaimana bisa menurunkan dosis sampai berapa sehingga relatif aman untuk paru-paru, ya, liver, as well as untuk tentu lensa ya.
Yeah.
Bagaimana tuh?
Yeah, Prof. So let me translate his question. So in your presentation, you mentioned that in the 2D era where long SSD, the dose rate has an impact on the pneumonitis. And when we are doing this IMRT type of radiation, the dose rate is high, right? It's standard. We just keep the dose low. Why it has no impact now? So the dose rate, when we do long SSD, it has an impact. But why now? When we do this,
we can go
yes,
for
with
the higher
IMRT,
dose rate.
yeah, the dose rate is standard, right? Why
Yes.
it had? Why we only keep the lung dose below 8, but why it has no impact? While in long SSD, that has an impact.
With long SSD, we irradiate the whole body in one time. Right with Regimen, we start from the head to feet. It's taking much longer time, even if we do the same dose rate. And unfortunately, about the dose rate, we only, it's really long time ago. I mean, like we've been using below 15 gray without very strict, not knowledge, but the evidence is not that high. We've been doing that because past people said it's safer to use low dose rate, and we can imagine high dose rate to whole body in 1 second will kill patient. We know that, but if we can change the intensity of we can lower the intensity. That means it's lowering the dose of the one fraction dose will be much lower than long SSD, using long SSD in the first place. And we've been doing this, and it's been more than 10 years by now, and the data shows it's as safe or more safe than long SSD data. So, but the thing is, chemo is changing as well. So it's very difficult to really compare the data from the 10 years ago or 20 years ago to today's data, but the result of getting the complete remission, the safety, short time safety is not below the 20 years ago. So we have to move forward.
Okay, so let me translate. Prof, jadi infonya bahwa kalau dulu kan kita katakan kalau tadi juga dipresentasikan bahwa kalau teknik long SSD yang 2D itu bila diberikan dose rate yang lebih tinggi walaupun dosisnya sama, dikatakan ada sedikit peningkatan pneumonitis. Tapi dari 10 tahun terakhir di Jepang itu mereka sudah mempraktekkan teknik IMRT yang mana dose rate-nya sebenarnya standar seperti IMRT sekarang, hanya dikunci dosisnya tidak lebih dari 8 gray pada paru min dosnya, dan ternyata itu aman. Jadi lebih penting adalah dosis absolut yang diterima pasien daripada dose rate yang diberikan, Prof. Ya, dan sulit membandingkan. Iya, kalau mau bandingkan dulu kan long SST kemonya masih beda dengan sekarang. Sekarang kan kemonya sudah jauh berkembang. Jadi mengcompare secara langsung akibat radiasi itu sulit. Tetapi yang jelas dengan teknik saat ini yang mereka lakukan dengan IMRT, kita mendapatkan kepastian dosis yang lebih tinggi. Kita bisa kontrol dosis pada ginjal, pada paru, dan ternyata dose range-nya kan biasa, tapi aman gitu, Bro. Bahkan mereka min dose-nya sedikit lebih tinggi 8, antara 8 dan 10 juga pengalamannya bagus, Bro.
So I have this, I'm sorry to show, this is Japanese
Bro, masih,
slide.
masih kimut.
Share like my see.
Handoko,
Can you show this? Is that possible?
jadi mereka dengan teknik ini dose rate yang paling rendah yang tercapai berapa ya?
Dosanya biasa, Bro, kayak MRT.
Biasa.
Iya biasa,
Oh
1000
ya,
MU per menit.
ya karena
Iya.
kita juga sama 8 gray, tetapi dengan dose rate yang sangat rendah sekali. Dan itu relatif lebih aman terhadap kejadiannya pneumonitis radiasi ya. Oke.
Iya, Bro. Jadi
Baik, terima kasih deh. Kalau memang itu mereka sudah terbukti bahwa cukup baik ya.
iya, Bro. Jadi yang penting adalah dosis total yang diterima min dose pada paru. Tapi mau di deliver dengan dosis rendah atau tinggi nggak terlalu problem.
Ya, tapi kan dosis total itu tergantung juga dari dose rate ya. Makin tinggi dose rate kan efeknya makin tinggi.
Prof Jaka asked if we are using current standard dose rate like 1000 MU per minute, it really has no impact with
Side effect?
with let's say 15 centigrade per minute. That is
So
like 10 times.
what, but I can show you is maybe can you share the screen? I'm sorry, but this is written in Japanese.
Okay.
I couldn't translate. How do I do this? It's like PDF. Not this one. Not this one. I wanted to show you. So this was done by other doctor from Dokter. Oh. Okay. So this is the data of overall survival by TBI done by IMRT in Japan. Not many people, but they delivered 12 grain 6 fraction with cyclophosphamide, and there was no pneumonitis, radiation pneumonitis. And there was, unfortunately, the kidney failure in 6 patients, and in later period. So, but 2-year OS of 69% is much better than the previously reported with low these are those right. This is very nicely spoken by other doctor, but this data, this is the comparing the high dose rate to low dose rate. But with low dose rate, the pneumonitis was higher in the high dose rate, but they still have 10% of pneumonitis. And then with IMRT, when we reduce the mean dose to 8 gray, then there's none. So it's one fact that we can show, I think.
And maybe
This is by long, this data come from long SSD, and the other one comes from IMRT.
and maybe with long and SSD with more uncertainty, probably the higher dose rate, the actual dose being delivered is higher. Right? That is why we see higher pneumonitis rate.
Yes, I mean, like lung, we don't really know how much lung we're getting. We tried our best to simulate, but still we are not really sure what we are really getting. And in our simulation, when we are delivering like 12 gray, we think the lung is getting around 10 to 14. So maybe average was like 12 in the long SSD of our institution. But there's no way we can really be sure how much they were getting.
Okay, thank you. Jadi Prof Jaka tadi dia tunjukkan kurva apa efek samping. Ini yang dengan IMRT dose rate-nya biasa seperti sekarang ya, dose rate-nya tinggi dengan survival yang bagus dan kejadian pneumonitisnya juga tidak meningkat. Dibandingkan ada grafik satu lagi yang tadi ditampilkan yang ada tulisan low dan high itu dengan yang teknik dulu yang long SSD memang di sana low dose rate itu lebih rendah sedikit, tetapi itu bisa karena banyak ketidakpastian, Prof. Mereka juga tidak tahu secara pasti dosis yang terdeliver pada paru. Jadi bisa saja mungkin pada yang high, yang lebih tinggi dose rate-nya sebenarnya dosis yang terdeliver juga lebih tinggi. Yang pasti adalah dengan teknik IMRT dengan dosis biasa yang tinggi ini itu tidak meningkatkan risiko pneumonitis, Prof. Prof masih ada di mute. Masih mute, Prof.
Ya, terima kasih. Thank you very much.
Thank you. Maybe
Thank you.
any more question? I think we have a question from our nurse. What any special precaution for nursing care before? Yeah, this patient will receive TBI only here, and the chemo is not yet started. After TBI, then any special care during these 3 days of radiation for the nurse. Maybe the cell count will drop, but I think it's not immediately drop, right? So maybe just hygiene, make it more clean when serve the patient.
About this patient, you mean?
Yes, for this.
If we have the TBI first and then have the chemotherapy, what?
So what special nursing care necessary for the nurse?
Well, the TBI is just a part of HCT. So we don't, like in breast cancer or any other cancer, if we are to give very strong treatment, we don't want to break. So right after TBI, they should really start chemotherapy. There shouldn't be break because we kill a lot of tumor cell, but if there's break, they increase. So the best thing we can do is send him to the hospital who's going to do the HCT, and they have to proceed. They them to not miss the right timing of doing all treatment. If we do one and have 3 days break, then it's the treatment effect will be lower. So it's really good if you could complete whole thing in one hospital, but if it's difficult, you guys chose the best way that we do the irradiation first so that the blood count won't be 0 at the time of transportation. So send them as fast as you can, and then them to continue and have transplant in the right timing. So communication with the other hospital is the most important thing. And the patient, in terms of patient, I think he will experience nausea. So, take care of the nausea.
Give anti-nausea drug.
Nausea,
Okay,
yes.
thank you. So for our nurse, Kak Bian, ini pertanyaannya udah ini ya, mungkin bisa mual dikit, jadi disiapin aja obat anti mual. Okay, any more questions?
Yeah, thank you, Dr. Mariko, for your presentation. So when the other hospital, the National Cancer Hospital, asked us to do the TBI, yeah, at the time I was like, oh, this is something that very big, and then we don't have any experience of this, but we have the technique, but we don't know. So it is like the timeline that they are giving to us is like very short. So in the short time, we try to do everything to ask our colleagues everywhere. So thanks God, you respond very very nice, and then because of support from you and colleagues, it makes ourselves more confident, because we came from nothing. We came zero experience about this, but with your support and guidance, we become more confident of this. Even though the process of radiation is not yet coming, but we experienced that the setting up is very hard, actually. Actually, it's very, very hard. And I would like to thanks you and Miyachi-san. And then also, I would like to also thanks to our supporting team here, because I saw that the setting up of the position, making the immobilization is very hard. You know that our base plate for the VEC lock back, actually it doesn't match with putting the muscular thermoplastic. So our technician do modify that can make a thermoplastic mask can be put it in so the VEC lock. So that is also a very amazing job by our technician. So I think I don't have any further questions. You already explained in these past 2 days. So maybe we will see how is it next for the radiation, and then maybe when you already go home back to Nagoya, yeah, we can still do a Zoom or communicating. Thank you very much, Mariko Sensei.
We connected. Yes. Yeah, I mean, you guys did really, really good job, because in the beginning, we had no idea where to go. And now we are seeing the same goal, and I'm sure you can achieve the goal. So congratulations. It's not done yet, but congratulations. And I think you have to now spread this in your country, and how the positioning is difficult and so on.
Oh yeah, one another question. Maybe it also connected with the Linux SSD that you have presented before. How do you think in our center, you saw our Versa room, right? So how do you think in the future we can do the TBI with this Linux SSD technique rather than Radixact?
Well, with long SSD, it's once you know how to do it, it's very easy. Well, I say it won't take long time. So for the relapse patient, who don't have really time to prepare, we just go with long SSD because they don't have time, because their stem is 0 at that point, and it's not, they can't wait. So if they relapse, if they fail the HCT, we plan TBI like in a week. We have to plan TBI in a week. So in that case, we still use SSD, long SSD, because it's faster. But considering the uncertainties, this is long SSD isn't the, well, there's so many things other than TBI, like chemo, the timing, the match of the HLA, and so on. So it's so many things that TBI, we are not really sure what is doing wrong with, it's not just TBI's fault. It's HLA mismatch and so on. So, but by doing Radixact, we will be a bit close to what we are really doing. So if something, certain things happen with the 8 gray below or higher, then it's TBI that's doing the bad. But with long SSD, we are really not sure what's doing bad because we are not really sure how much they are getting. So to get the idea of the weight of TBI, we have to be certain about physics. And I think IMRT is one of the answer that the way to give the answer. Am I answering right?
Yeah.
So that's why we don't go back for SSD. We want to give the answer to the treatment dose.
Okay. So another question I would like to ask is regarding the patients. So fortunately, our patient is very cooperative, right? Fortunately, very fortunate that our patient this time is very, very cooperative. He can stand still for like 2 hours or 3 hours now. What do you think if the patient is a pediatric patient? What the things that we need to focus or consider?
So unfortunately, we really want to apply TBI, IMRT TBI to pediatrics, but because of the difficulty of fixing pediatrics, we are still doing long SSD for pediatrics because they cannot stand that. With anesthesia, we don't want to give so long anesthesia, so we just let them sleep. Pediatrics, we just let them sleep, not fully anesthetized. So in that case, if we take too long, they'll start to move. If they're just sleeping, they move. So we have to, we cannot do the IMRT to pediatric at this point. Maybe in future with AI, the fixation will be very fast and surface guided. If surface guided can do the surface guide and recalculate in like second, then yes, we can do for pediatrics. But at this point, we have to fix, and we need patients' cooperation. So we need certain target for this treatment. And all people, they don't tolerate 12 gray in first place. So it's usually we apply this to up to like 55 years old. So we don't do this to the very old people. So we usually do from 20 to maybe 50 years old patient. They are usually good.
Thank you.
Yes. Any more questions? Maybe online? Anyone online want to ask questions? No more. So thank you so much, Dr.
you.
Mariko. Thank you for coming and sharing your experience and teach us. And thank you everyone for participating.
Thank you so much.